Welcome to the Cold Steel Surgical Podcast with your hosts Amir Farouk and Chad Ball.
On this episode, Dr. Elizabeth Squirrell joined us to talk about Crohn's disease. Dr. Squirrell is a staff gastroenterologist at Queen's University. In this two-part series, we first talk about the diagnosis of Crohn's disease and the different patterns of its presentation. In part two, we talk about the changing landscape of medical therapy for Crohn's disease and how Dr. Squirrell approaches the treatment of Crohn's. Make sure to check out the links below for all the papers that are discussed in both part one and part two of this series.
Come back to the whole abscess issue in a second, but can you tell us a little bit, maybe just in the interest of time, I really wanted to talk with you a little bit about some of the newer medications on the block for Crohn's disease, because it feels like, as you said, we're going through this revolution in terms of different therapies that are available now for patients with Crohn's disease. Maybe you can start us off by just talking a little bit about the different classes of medications and maybe a little bit just to begin with on the old school Humira and infliximab and talk about that a little bit, but then also tell us a little bit about some of the newer therapies that are on the market.
So there is a ton of medications coming in the pipeline and currently available now. If you go back to, I think 1999 or early 2000s was when infliximab became available. And that was truly the only option at the time. Since then, we've gotten a lot of different options, and not just biologics, but we also have small molecules now, which are synthetic medications. They're not monoclonal antibodies. So they come typically in pill form. And so that is very helpful to patients who have different preferences around injections versus infusions versus pills. Though I do find that once somebody wraps their head around the idea of an infusion or an injection, it's actually a bit easier than remembering a daily medication. But going back to the kind of infliximab, the adalimumab, the early days of biologic therapy, and we think about the way I think about it, and maybe simplifying it to a degree, is that we have this inflammatory pathway, and we know that at the end of the inflammatory pathway, all roads there led to TNF. And adalimumab and infliximab target TNF or TNF alpha. And so you're targeting the kind of downstream effect of the inflammation that's causing the symptoms, right? Your immune system has led to this inflammatory cascade and to too much TNF, too much inflammation. And the infliximab is a very good target for that. Infliximab and adalimumab, they both have a lot of biosimilar medications available now, which are, we can't say generics because they're monoclonal antibodies, but kind of that idea. So it's still the same, it's still infliximab, it's still the same drug, but it is made slightly differently by each biosimilar manufacturer. But we do use them interchangeably now. That has really opened up kind of the medical options as well for people, because it opens up the affordability to a degree as well.
That's like Inflectra, right?
Yeah, Inflectra. So the kind of the old brand would have been Remicade, and now we use Inflectra and Renflexis. I think there's a couple others, and then adalimumab has more than I can pronounce for their biosimilars. The TNF inhibitors, they do have slightly more side effects. They're a little bit, when you target the downstream effect, you're less targeted, right? And so you have a little bit more immune suppression. And they also have a higher rate of antibody formation or loss of response than some of the other medications. And that we see over time that with infliximab, the goal was to start your patients on infliximab with an immunomodulator. And that's what the original trials for infliximab looked at. And that is more immune suppressing when you're having to use azathioprine or methotrexate in combination with these medications. And then you have to think about the side effects of the azathioprine and the methotrexate as well. And so these ones are a bit more immune suppressing, still not to the same degree as, systemic steroids and things like that. But they also have a higher rate of immune-mediated side effects. So people developing things like psoriasis on the drug, people developing, there's really, really, really rare cases of things like MS and lupus. And so these ones, over time, we've tried to get more targeted therapies. But we still know that infliximab for, the acute severe colitis in hospital, that's our rescue therapy. It's still a really, really good drug. It works really quickly. It gets people in remission, and it can keep people in remission. And it still has a very strong role. It also has a really big role for patients with perianal fistulizing disease. That is one of the only ones with robust evidence for perianal fistulizing disease. And it has a bigger role for people with extraintestinal manifestations. So even though the TNFs are a little bit less selective, they have potentially a few more side effects. Sometimes that lack of selectivity is important when, your eye is affected, right? Or your joints are affected. Sometimes you need something that's going to also focus on the eye and the joints. And so those are the patients that I still gravitate to the TNF inhibitors in. And the patients with the penetrating disease at diagnosis, with the deep ulcers that I'm really worried about, those are the ones that I'll still kind of gravitate to infliximab, adalimumab early on. So that's kind of a brief overview of TNF inhibitors.
Our audience includes medical students and residents. So can you just talk a little bit about immunomodulators as well? Like you said, you mentioned azathioprine, because you'll read in the guidelines of that is sometimes still offered to patients for mild disease.
Yeah, a lot of the guidelines are 2018, 2019, around there. A lot of them have been published. And so a lot of the newer medications weren't actually available at that time. The azathioprine, there is good evidence for azathioprine maintaining remission in Crohn's disease. There isn't good evidence for inducing remission, but there is good evidence for maintenance of remission. And there's evidence for methotrexate maintaining remission. I like to view it as this kind of selective and non-selective immune suppression, probably oversimplifying it for myself. But neither of those are all that selective of a medication. They're relatively broad immune suppressing medications, and they both carry a bit more potential toxicity than what I view as the typical risks with biologics. They're good medications when they work. So we have some patients who've been on azathioprine for years and years and years. And for the patient with mild disease, mild to moderate disease, who has a lot of symptoms, if they get that under control and they prevent you from developing strictures just with the azathioprine or just with the methotrexate, and you tolerate the medication, then I think there is still a role in those patients. Most of the provincial formularies and the insurance coverage have updated their practices to allow for what we call a top-down approach rather than a bottom-up approach. Because what we found with starting with a steroid trial and then going to azathioprine and then going to a biologic and then maybe trying another biologic was that fibrosis started, right? And then it's harder to abort that process. And so we found that while there are some patients that it works for, as a general approach, starting with the biologics rather than azathioprine or methotrexate is probably going to have a better quality of life impact, fewer surgeries, better benefit in these patients. And then the other thing with the azathioprine and methotrexate are that in long-term use, they do have a bit more toxicity. And azathioprine specifically, we think about a lymphoma risk. It's still a very, very, very low risk. I probably in practice see more skin cancers with azathioprine, not as much lymphoma, but more skin cancers, especially in long-term use. And the things that we sometimes don't think about are things like infection-related cancers, so HPV-related cancers. And so that's something that people on long-term azathioprine should be having annual PAPs. Those are things that we think about it as an earlier step than the biologics, And I think that makes it feel a little bit safer to some people. But in long-term use, there is potential toxicity. And when we think about those risks and benefits and how it truly works, I think we're moving away from those a little bit more. The practice may evolve more. My general practice is that I will continue people on them if they're doing well on them. When they're over 60, I will stop azathioprine. And if we need to start something else, we need to start something else because the lymphoma risk is increased over 60. And I'll use both azathioprine or methotrexate in patients who, say, with perianal fistulizing disease in combination with the TNF inhibitor for at least the first year of treatment to give them the best response to the TNF inhibitor. But that can be in a lower dose when you're using it in combination as well. So that's a long-winded way for me to say that I think the practice is probably moving away from them as we get more targeted options. But there is still that slight role in certain people. But we'll see kind of as time goes on what updated guidelines say with the role for azathioprine and methotrexate.
Gotcha. Okay, well, that's very helpful. And you were starting to tell us about some of the other classes of medications now that exist besides the TNF inhibitors and immunomodulators like azathioprine.
Yeah, so when I try to think about these, I think about the other biologics, and then I think about the small molecules. The other biologics that have come down the pipeline, the first one that came down the pipeline was, well, it was actually natalizumab, which we are not using, but its cousin medication is a little bit more targeted. So Entyvio or vedolizumab, and that's a very gut-specific medication. So a lot of people really like the idea of vedolizumab because you think about it targeting the gut, so it's targeting the problem, right? And it affects the immune system of the bowel. It's an anti-integrin therapy, so it targets alpha-4 beta-7. It works on the same premise. So the older one, natalizumab, it worked, but it wasn't targeted to the gut, and it had a risk of severe neurologic side effects in some people. So we don't tend to use that. But Entyvio, there was some kind of caution about could this cause the same side effects? And over time, we found that it doesn't. It truly is a gut-selective medication in that way. It's a very good medication. I think it has a bit of a bad rap in Crohn's disease specifically. And a lot of this comes down to how different studies were done. So they tried to measure success with Entyvio at the 6-week mark instead of the 8-week mark, if I'm remembering right. And if that had worked, that would have been really great for that drug because they would have been able to say, look, it's a really fast drug, but it didn't. And so now there's this kind of reputation of Entyvio is really slow. And Entyvio has a little bit of a bad reputation in Crohn's disease as well, in part because of how the studies were set up. If you look at the long-term data for Entyvio, when people do respond to Entyvio, they have a lasting response to it. So it is a good medication for those patients. One of the things that a lot of people also like with Entyvio is that it is either infusion or injection. So patients get to choose after the first few doses whether they want it as a needle at home or whether they want to go into a clinic every 8 weeks. It does lose some of the potential efficacy if it's used after a TNF medication. And so that's something that I'm aware of also with it. And so there are some people who will practice by using it a little bit earlier, maybe trying it before a TNF. Usually I would do that in somebody who doesn't have a clear reason to be on a TNF inhibitor. I think it's a good medication, but it is also one that I will kind of make sure that I'm not going to burn a bridge with the patient if it doesn't work, right? And then they've done some studies with other medications similar to that, but they haven't become available in Canada. So that's the only kind of gut selective one, which patients tend to really like. It tends to be really well tolerated also. There is a very, very slight increase in sinusitis and kind of coughs and colds. And some people notice some joint pain on it. And whether that's because it doesn't treat the joint pain from the Crohn's disease or whether it's because it actually causes it, it's a little bit unclear. And then the other kind of newer biologics, we got Stelara next, or ustekinumab. which is a interleukin 12 and 23 inhibitor. Again, we're getting a little bit kind of more targeted in the inflammatory pathway that seems to be a culprit in Crohn's disease. And so this one, it targets both interleukin 12 and 23. And that seems to be quite good in patients who have psoriasis as well, especially if they have drug-induced psoriasis on the infliximab, because that seems to be kind of the pathway that gets overactivated when you develop that. And again, in these patients, if you respond to it, it seems to be quite a durable response. It doesn't seem to, in general, if you have arthritis or a lot of extraintestinal manifestations, it doesn't seem to have as much of a benefit. And then we get to the Squirrell, which was the IL-23 inhibitors. So they looked at the IL-12 and 23, which the ustekinumab or the Xolair targets, and found that if you target just one of those, it actually seems to be a little bit better. And so that's what the IL-23 inhibitors have been targeting, is just 23. The 12 was kind of a bystander that didn't seem to have much benefit by targeting it. And so there's a few different IL-23 inhibitors that are becoming available. There's one for ulcerative colitis that's available right now in Canada. The risankizumab or Squirrell is for Crohn's disease in Canada. I think the names could be easier to say, but there's a few more in the pipeline. So far, the data looking at the IL-23 inhibitors seems that it's going to be even more promising than the 12 and 23. But the head-to-head kind of between the two, one, it's an open label study, so patients knew they were getting the new med or the old med. And two, it's only been presented at conferences so far. It does seem to have a bit better efficacy than just ustekinumab, but it's hard to know. So we'll see with that, but it seems to be a really promising option. And again, when it's more targeted to a specific part of the inflammatory pathway, seems to have fewer potential side effects. And then those are really the big kind of biologics that I think about. One of the things that I can go through all these lists and say numbers and say things that come out of the studies. And again, a lot of this, when I speak to patients about this, a lot of what it comes back to is I don't have that crystal ball. And there's some people who are going to respond really well to one of the medications and not another one. And we know that the first biologic that you're on, if it works for you, that's the one we go with. That's the one that's going to have the best benefit at preventing your disease from having complications. And so it becomes a bit of an educated guess at times. There's more studies going on right now to kind of look at histology and see if you can take a biopsy and look for a certain cytokine or marker and then see which drug will work. And some of those seem promising and some of them don't. So I think we'll have a lot better evidence to support which medication we choose as time goes on. We aren't quite there yet. So those are the biologics. And then there was a push to look at other ways to get these medications to target the inflammatory pathway, to target the problem. And some of those ways were the small molecules or more synthetic medications rather than the proteins and the monoclonal antibodies. There's two that we think about that are more commonly used. One of them, the tofacitinib, you might be familiar with because we do use it in hospital sometimes for acute severe colitis. That is a bit of a new use for it. They're very fast medications because they're just how they work. They're pills. They're not an infusion that takes a while to distribute, and they work quite quickly, and they have a kind of a fast onset, and they come out of your system quickly if you need to stop them. The tofacitinib, that's Xeljanz.
I know we're not supposed to use like the trade names, but sometimes I feel like unless you mention it, people don't know what you're.
Yeah. That one is not currently available for Crohn's disease in Canada, but its cousin medication, which is another JAK inhibitor. It's a more targeted JAK inhibitor. It's called upadacitinib or Rinvoq. One of the things I do tell patients about these medications is that while they're very new to Crohn's disease in Canada, they have been used for other diseases over the last few years. And so we do kind of operate also using some of the safety data from like rheumatoid arthritis and psoriasis. The upadacitinib, because it is a little bit, again, more selective as a JAK inhibitor, it targets one pathway rather than multiple. It may have a better safety profile than the Xeljanz, but it's hard to say. So right now we kind of caution people based on the safety profile of Xeljanz, which when they looked at rheumatoid arthritis patients and they looked at post hoc analysis, they did find a signal for adverse cardiac events in older adults with rheumatoid arthritis with other risk factors for cardiac disease. And so that's not really the common IBD population, but it is something that we talk to patients about. It's a lot of ifs to get there, right? It's a different population. It's actually a different drug. But when we think about this, it probably has a slight increase in clot risk. And in patients with high cholesterol or other cardiac risk factors, we do know that it increases cholesterol. We need to monitor that. And so it is reasonable to suspect that it may increase some of your cardiac risk. And so there are medications that they work really quickly. They work really well when they work, but they do have slightly higher increased risk than the biologics, even though, again, a lot of people will kind of view a pill as like a safer option than an infusion. But I think when you weigh out the potential side effects with the medications, they do have a slightly higher risk. The other thing that was a signal in the studies for Rinvoq especially, and this is relevant in the surgical setting for sure, is that there was a slightly higher rate of perforation in patients on JAK inhibitors if they had significant stricturing disease when they started it. And so that's something that I'm a little bit cautious with. I don't completely avoid them, but I'm cautious. The last thing that actually I'll only say because it has a funny name, but some patients will tell me that they get a bit of acne when they're on the JAK inhibitors. And it wasn't as commonly reported, but I found it a little bit more common when I talk to patients now. And one of my patients recently looked it up in a forum and they call it JAKne, which I enjoy. But it does get to the point for some people that they're like trying to come off the medication because it can be a fairly significant acne reaction. It's one of those things that you don't think about when you're finding a new drug for IBD, but it's real.
That is fascinating. It really is fascinating how many choices we have now. So let me ask you this. Are there any tools out there that can help you sort of say, like you put in some disease characteristics of the patient and it'll give you some suggestions? Because I would imagine that even as a provider, it's very difficult to actually think about what would be the ideal. It's almost like, I almost feel like this is like the precision oncology kind of equivalent, right? Like, you really have to tailor your therapy to the individual patient sitting in front of you. That's the first part of the question. The second part of the question is how on earth do you go about explaining this to patients? Because there's so much, potential side effects and risks and, balancing all of that in any sort of statistical way that makes sense is very difficult for the average clinician, let alone the average patient.
As we've gotten more options, it's become harder to have that conversation and to go through that, right? We know that none of these medications are perfect. So I always start the conversation with, we're going to go through these steps with the information that I have about you and your disease. They may fill in some blanks for me, like, have they ever had psoriasis? Sometimes we forget to ask that before. And is there a family history of high cholesterol, right? But we start with, we're going to use what we know about how your disease has behaved and kind of your age, your risk factors. And we're going to pick the one that we think may be the best for you, but we don't know that it's going to be the best one. And so we're going to monitor closely and we're going to have a low threshold, in 6 months to a year, we reassess and we change if we need to. To have that conversation off the bat is important because you may pick the wrong one, right? And even if you don't get full remission on these, a lot of these will have at least a partial effect for people. So you're still helping them feel better. But my usual kind of algorithm, because I don't know if there are kind of an algorithmic tool to use. Brian Bressler last year I think in 2023 he published this, but there was a paper that he put out just talking about sequencing of these medications for patients with inflammatory bowel disease. And so what pushes you to start one or another? And so that's a really good reference for people when thinking about what factors push you to start one drug or another. I used to just present all these options to patients, and some patients want all the options. And so for those patients, I'll write things down for them, let them do some reading because they're going to read about it anyway. And then we'll revisit at another appointment. Because it takes a lot of time to go through all these details. So if they want every single option laid out, then they have a little bit of homework to do. I think that this is where you as the physician, your expertise and your opinion on it, what you kind of sort out as the patient's values, you're the bridge in between those things, right? And so I don't have to go into a room and tell a patient every single one of these options.
Dr. Squirrell, thank you so much for joining us today. One of the questions we asked all of our guests on the show is, if you could go back in time and give yourself advice as, let's say, a chief resident, knowing what you know now, what advice would you give yourself?
Oh, that's a hard question. This is not deep advice or meaningful advice, but it would be to buy a stand-up paddleboard sooner than I did.
Was that something you started doing in Vancouver?
No, I started actually this year. I had been a couple of times before, but I just got an inflatable one and it's in the car, and then I pump it up when I'm by a lake, and it's great. But I think that speaks to a little bit more. I really encourage people, if they have the opportunity and if their life would fit with it, to take a year to do a quieter fellowship and to go to a place that you want to spend a bit of time in. Like, I didn't see myself living in Vancouver, but living there for a year was spectacular. And having a little bit more time, not being on call quite as much, not having that same kind of your own patient load yet. It's not a luxury everybody has, but it was really nice to just be able to you kind of reset a little bit, right? You get back to figuring out what your hobbies are outside of call, because that's not a hobby. And getting back to, okay, what do I enjoy in different activities and things like that? And getting outside more. And when you get time in your life, I think reset and go outside.
That is fabulous advice. Thank you so much.
You've been listening to Cold Steel, the official podcast of the Canadian Journal of Surgery. If you have comments or questions, please email us at podcast.cjs@gmail.com. Thanks for listening.